Hello, and welcome to this MedThority VTE podcast series. My name is Jeff Barnes. I'm a cardiologist and vascular medicine specialist at the University of Michigan, and I'm thrilled to be joined today by my really good friend, Dr. Greg Piazza, also a cardiologist and vascular medicine specialist at the Brigham and Women's Hospital and Harvard Medical School. Greg, thanks for being here to talk about venous thromboembolism.
Thanks so much, Jeff, for having me. It's great to be able to join up and do this together.
So, Greg, I wanted to start with a conversation around venous thromboembolism, and sort of one of the big questions that we always have is, after a patient has VTE, what's their chance of having another venous thromboembolic event? And I'm wondering if you can walk me through a little bit of how you sort of conceptualize the risk of recurrence with venous thromboembolism.
Yeah, of course. Yeah, it's a great question. It's one of the key things that comes up in our vascular medicine clinics. And as you know, we used to divide things into provoked and unprovoked, and that helped to color which way we were going to go with extended therapy or not. But the more recent data and guidance actually requires us to consider patients' intrinsic risk factors for recurrence, as well as whatever happened to them that could have been an external or extrinsic factor. And so really what I use is the circumstances around the venous thromboembolic event. Did this happen because there was a strong or maybe not as strong provoking factor, or in the absence of any identifiable provoking factor? And then what does the patient bring to the table in regard to sort of enduring risk? Do they have a chronic medical disorder that predisposes them to having another thrombosis, obesity, heart disease, lung disease, taking into account all of these different things, cancer, to sort of develop a pre-test probability or a pre-decision probability about what to do and what's their risk of the blood clot coming back.
You know, I love that you brought that up, because I remember going through training and it was that dichotomous provoked or unprovoked, right? The patient who had a blood clot shortly after a surgery or while taking an estrogen-containing hormone contraceptive that was clearly provoked, short-term anticoagulation, were done. And then everyone else was unprovoked. And I think we've moved into more of this nuance that there are multiple risk factors, some that are transient, like that recent hospitalization or maybe the cast that somebody has on their ankle. But others, as you mentioned, are persistent. And the one I think I've underappreciated a lot is obesity, and just how important a risk factor that is for venous thromboembolism. And of course, then that's going to shift how we think about treating patients and what their risk of recurrence should be, you know? And so I want to transition over to that a little bit. Let's start with some of maybe the observational data, and there's been data for several decades now helping us estimate the recurrence risk for venous thromboembolism. And so when you talk to patients, what kinds of numbers do you use? How do you describe their risk of recurrence as it informs your decisions around anticoagulation?
I find the European Society of Cardiology guidelines, that table that's color-coded, to be extremely helpful. It divides patients into three categories: low, intermediate, and high risk for recurrence. A low-risk patient would be someone who has a less than 3% chance of a thrombosis recurring when they stop their anticoagulation. This is what we traditionally thought of as patients who sort of had a major provoking factor like hip fracture or surgery. Then you have your intermediate risk patients. These are patients which sort of include that minor provoking or minor transient provoking factor. Both the ISTH and ESC speak to factors that maybe in the past we sort of recognized as maybe being more common in patients with venous thromboembolism, but we said in and of itself maybe not strong enough to explain everything that happened to this patient: birth control pills, travel, minor orthopedic trauma. But now there's increased awareness about the fact that if you have one of these minor provoking factors, and maybe you have more than one, you can build a sort of risk that could lead to pulmonary embolism or deep vein thrombosis. And so these intermediate risk patients have somewhere between a 3 to 8%, roughly about 5% chance of the thrombosis coming back. We also, in that population, take into account patients who have persistent or enduring risk factors. So what are they bringing to the equation? Is it obesity? Is it immobility that's sort of persistent or comes with them? Is it heart disease, lung disease, kidney disease, those sorts of things? And then we have a very special population of patients. They're in the red zone in this color-coded table. They have a greater than 8% chance of thrombosis recurrence. And this is inclusive of patients who have malignancy, where we know that that risk of the thrombosis coming back if they stop anticoagulation is quite high, but it also could include some severe thrombophilias and patients who might have recurrent thrombosis, especially unprovoked. And so that's how I actually use that table to talk to my patients. I draw it out for them, and it really seems to make it very real, very visual for patients.
Well, and I like that sort of 3-level structure. I think it's easy for patients to understand. Yeah. But it's also helpful because I think it's leveraging real world data. So you can say this comes from data in patients like you. And so one of the questions I think we as clinicians then grapple with is, how do we take some of that clinical trial data, right, that really high quality data, but that's maybe in more selected patients, and how do we apply it to the patients we're seeing every day in clinic? And so I want to ask you specifically about that decision to extend anticoagulation. And so how have you maybe changed your practice in the last 5 or so years around not just who you're giving extended anticoagulation to, but maybe even what kinds of extended anticoagulation you're giving? And how have you looked at sort of randomized trial data and real world data to bring that together?
Yeah, well, Jeff, I'm happy to say that you've influenced me in how I sort of approach my patients. You know, I think it was maybe more than 10 years ago, you really brought to the table this idea of shared decision-making about anticoagulation. And it wasn't necessarily something that I saw my colleagues doing when it came to making decisions about extended secondary prevention of venous thromboembolism. But I think that it really planted a seed and stuck with me that there are a number of things we have to put in when we're having a shared decision-making conversation about extended duration thromboprophylaxis for preventing DVT or PE recurrence. One of it is, you know, what benefit do we expect the patient to get? What's their risk? Because their risk drives their benefit. If their risk is low, anticoagulation may not offer much benefit. If their risk is high, it stands to offer a great deal of benefit. What options do they have for anticoagulation? Are they someone that might benefit from a low intensity regimen that we see with some of the direct oral anticoagulants? Or will they need a more robust sort of full intensity? I'm a big advocate of considering bleeding risk. I do feel that our patients have who have increased risk after their first venous thromboembolic event, even if it's provoked, that risk does attenuate to some extent. If you look at all these different graphs, there is, as they get further out from the index event, there is a decrease in that risk. Whereas with anticoagulation, there's sort of a yearly risk of major bleeding, and it doesn't really change from year to year. It might actually increase as patients get frailer and older. So those things have to be sort of balanced. And I use actually a bleeding risk score. I use VTE bleed, but there's a lot of other scores that we can use. I don't use it because the number matters so much to me. I use it because it helps me to explain to patients, you know, you're over 60. You have anemia, you've had a major bleed, you have chronic kidney disease. I use these things to explain why we have to talk about bleeding, actually, right? So many of my colleagues for so long didn't talk about bleeding. They just talked about how great extended anticoagulation is, but bleeding is part of a good shared decision-making conversation. And then the last thing I talk about is sort of patient preferences. And that could be anything from, I don't want to be on a medication for the rest of my life, to I can't be on the police force and do the type of police work that I want to do if I'm on full anticoagulation. Or, you know, I run a construction business. I'm on scaffolding all the time. Are you telling me I can't go up on the high girders? And, you know, so these are things that are really key. It could also be skiing. For you and I, we're tennis players. It's less of an issue.
Yeah.
But if you're an avid skier, this could be a thing. So I really spend a lot of time on this. Like almost the whole visit is dedicated to this shared decision-making process.
So I love that you brought that up. And I want to sort of wrap our conversation up with one other sort of discussion point, and that is the bleeding risk. And we know from the randomized trials, when especially these oral factor 10A inhibitors were compared against a vitamin K antagonist, they did really well. They were highly effective. They had similar or lower rates of bleeding, less intracranial hemorrhage, sort of that most feared complication. And so we all began using them right away. And we even have these lower or half dose regimens we can use in that secondary prophylaxis phase. But then we've also now got some real world data that sort of raises questions between the different oral factor 10A inhibitors. And for you and I here in the US, most of the use, of course, is rivaroxaban and apixaban. And it's sort of raising some questions about, is one safer or the other? How do you think about looking at the real world data, applying that to your patients, understanding what the clinical trial data tells you, and helping your patients choose the best anticoagulant for them?
Yeah, it's a complicated process because it requires you to sort of step away from the randomized controlled trial data, which we're taught from day one of medical school as the gold standard. But when you take care of patients clinically, you realize that the randomized controlled trial settings a very specific subpopulation of patients. They've been carefully selected to have a low bleeding risk and oftentimes a high risk of thrombosis. And what I've really learned from the real world data is that yes, these direct oral anticoagulants really do reduce the risk of bleeding, but bleeding happens. It happens in the real world more commonly than we see in the randomized controlled trial populations. And we have to have a realistic conversation with our patients about how real that bleeding risk is. Now, some of these real world studies have sort of looked at relative rates of types of bleeding and overall bleeding between the different direct oral anticoagulants. We don't have head-to-head studies. So all of this stuff is very interesting. And there may be some certain populations where one direct oral anticoagulant may be preferred, either based on pharmacology or indication. But the important thing is to sort of recognize from the real world data which populations have risk, and to sort of make sure that that is weaved into the conversation when you're picking an agent. Because for some of these agents, we have more data in a certain population. We don't necessarily know it's better or worse than another direct oral anticoagulant, but what we have is more experience in that population. And that's what I like to talk to my patients about.
Yeah, no, you're absolutely right. Is helping patients pick the right anticoagulant for them is key. And you mentioned this when we were talking about shared decision making, that preferences or the patient's values are such a key piece. I can think of patients who've come to me and said, "Doc, I am so afraid of bleeding on one of these drugs. You have to do everything possible to help me avoid the bleeding." So we talk about, are you using aspirin? Are you using NSAID? Are you drinking? How do we sort of manage those other risk factors? But then I might suggest to them that apixaban has been shown to have a very low rate of bleeding. And for them, that might be their preferred agent. But similarly, I have patients who come to me and say, "Doc, I can't take pills twice a day, or it's too expensive, or I just something simple." right? And for those patients, I'm so happy to have rivaroxaban as a great option, much more convenient than being on a vitamin K antagonist. So it's really that personalization and talking with patients to figure out what's going to be the best drug for them. Because at the end of the day, we want them to take the meds so they don't have recurrent VTE. But we want them to do it in a way that's safe so that they're not bleeding. And I know you probably have very similar conversations with your patients as well.
No, and I think that that's the key thing, is being approachable with your patient, and coming off as open to have this conversation. And together we're picking a good medication that you're going to be able to take reliably. I think, the old paradigm of, this is what you need to do, this is the drug I'm prescribed. I mean, that's out. And I think that being able to have a real heart-to-heart conversation with your patients, and to let your patients know that what they're looking for in a medication and the lifestyle matters to you, is how you provide the best care. Is everybody can have their favorite DOAC. If you're writing it for everyone, there are going to be some patients where it just doesn't work.
Yeah, you have to be flexible, and you have to have that conversation with the patient. I love that messaging. Well, Greg, this was so much fun. Thank you for joining us today on this MedThority VTE podcast. We've learned a lot. And for all of you, I hope you are able to join in for our next podcast. You can learn more at MedThority's website.
Thanks, Jeff.